Starting with diabetic eye disease, I will start actually with the definition of diabetic retinopathy. So, what is diabetic retinopathy? It's kind of potentially sight-threatening disease of small retinal vessels. It's chronic progressive disease. This is mainly because the prolonged high blood sugar or like hyperglycemia. Obviously, there are different also factors, including high blood pressure, high cholesterol, can be actually factors for this assessment for the diabetic retinopathy. So we have got quite a number of classification of diabetic retinopathy. As a clinician, as doctors, we deal with it. I've just tried to mention the just most common one, the American Academy of Ophthalmology Guideline Committee with modified ETDRS. They divided to two types: the non-proliferative diabetic retinopathy, which is the mild type and or moderate type, and the proliferative diabetic retinopathy, when we have got a little bit more advanced finding, we have got quite severe retinopathy, which warrant treatment. Also, another useful and important classification is the National Screening Committee, which we are using in United Kingdom, NSC, which maybe some of you may be familiar with, which if we have got like any clinical letters or like screening, you might be finding some letters and numbers. But to make it simple, it's retinopathy mean R. It's the type of severity of the retinopathy. It's can vary from 1 to 3. So R1 is the mild form, R2 the moderate form, and R3 the severe form. So this is the easiest type or classification we can use. Now we have also the maculopathy, which comes with M. So either we have got some involvement to the central vision, or we have got no involvement. So this is either M0 or M1. Also, we have got P, which got the photoregulation if there's any previous laser treatment, and U if we can't assess the fundus because of cataract or vitreous hemorrhage. So the questions: what is my symptoms? If I have got diabetic retinopathy, what should I be expecting? The honest answer: you might be not noticing any changes. You might be very little notice some blurriness of the vision if there is involvement to the central vision. But if the central vision is okay at this stage and there is no maculopathy, you may get like moderate to severe even diabetic retinopathy with no symptoms. Unless there is involvement to the macula or the central vision, then you will start to notice some deterioration of the vision, blurriness for distance or for reading, distortion. For the advanced cases, we may lose vision because suddenly get the vitreous hemorrhage. So that's important factors. It comes without noticing the diabetic retinopathy. So what do we see as a clinician, as a doctors, when we see the diabetic retinopathy, when we are assessing, when we see the retinopathy, what we are seeing? Obviously, it's vary from the early stages to the severe stages. So we can see exudate, what we called it. This is like fat deposit or lipid deposit on the retina. This is the yellow bit. We can see small bleeding, these dark red spots. We can see vascular changes, for example, widening or narrowing or torturing of the vessels. Also, we can see very fine, tiny vascular component, which called it IRMA, intraretinal microvascular abnormalities. And we can see also cotton wool spots. This is like a sign for ischemia, that the retina is tired. I'm trying not to be very much talking with complicated terms. If any other people would like to in order to people follow us, so I hope that's okay. So with the more advanced cases, when we have got the proliferative type or R3, we have got the new vessels when started to cause serious problem. This can lead to sudden loss of vision. It can lead to tractional retinal detachment. So we see actually this type of net around the disc or elsewhere, which cause they are fragile vessels and they can bleed quickly to the jelly or the vitreous inside the eye, can cause loss of vision, sudden loss of vision. So what the eye complications which link to diabetic retinopathy? As mentioned, there is risk of tractional retinal detachment, the progression of the cataract, optic neuropathy, where the optic nerve is being involved, also glaucoma, when we get neovascular glaucoma, special type, when we have got vessels growing on the angle, blocking the angle and increase the eye pressure, retinal vein occlusion, when we have got also blockage on the vein and cause extra bleeding, and optic disc swelling, when we have got optic neuropathy again. So what are the risk factors? The important thing is the duration and the age at the onset. There's the Western study. They mention if there is onset before the age of 30, the incidence of diabetic retinopathy after 10 years is around 50%. However, if it is the onset of the diabetics being actually diagnosed after 30, it's likely that we ended with diabetic retinopathy after 10 years around 90%. So this is it's important to see what we need to do. So this is how much this, unfortunately, we can't change it, the duration and the age of the onset, but we will talk more about prevention. The other risk factor, diabetic control. How good is my blood sugar control, HbA1c? The study showed that decrease 1% of the HbA1c, it reduced third of the microvascular complication. So 1% reduction in the HbA1c, it relieve third of the complication, including the eyes, heart, brain, kidneys. So that's a very useful thing to know. And usually we advise the value of the HbA1c is between 6 and 7. Another factor, blood pressure, smoking, BMI, the body mass index, the also is like increasing risk factor, pregnancy, and kidneys problem. I thought to share with you like few study which I think a lot of people know about it, but it's good to remind ourselves with it. So one of these, the Diabetic Control and Complications Trial, DCCT, which included around 1,400 people with type 1 diabetes. Half of them, they haven't got any diabetic retinopathy at the start when they done the trial, and the other half have got mild to moderate retinopathy. And they follow it around 6 to 7 years, and they found actually with tight control the blood sugar, they reduce the mean risk to develop diabetic retinopathy at around 3/4, 76%, comparing to the conventional therapy. So if the first group, which they have no diabetic retinopathy, with tighter control, around 76%, they haven't developed any kind of diabetic retinopathy over 7 years. The second group, when we have got mild to moderate changes on the back of the eye, they found that it slowed the progression of diabetic retinopathy around 50%, and with this for the severe non-proliferative diabetic retinopathy around 47, so around 50%. So that's good reduction. Same with the UK PDS, United Kingdom Prospective Diabetic Study. They recruited around 4,000 people from type 2 diabetes, and they found actually around 25% risk reduction with intensive group treatment with tighter control the blood diabetes and blood pressure. So in general, so there's quite good news. So if somebody has got the diabetes, we know that we can't do much about it at this stage, but apart from better control to blood sugar, which can reduce the complication in the eye and all the parts of the body. So what the management? What should we do? I feel that patient education is very critical and is very important, and that's why we are all here sitting in this meeting, actually sharing this experience. So educating the patient, telling them about what could happen and how we can avoid it is very essential. Blood pressure control, also controlling the cholesterol, hyperlipidemia, all things can help also with the diabetic retinopathy. There are a few studies. One called the field study also suggests some kind of anti-cholesterol tablets, fenofibrate. It can help also the diabetic retinopathy and including the exudative type of maculopathy. Also advised to stop smoking and just addressing any other factors like anemia or renal failure, and encourage people to lose weight and exercise quite routinely, and be like exercise properly in any way. So you just get the habit of our routine daily, just doing like half an hour walk, for example, healthy diet. So all this can help. Now, we have got treatment. If to happen this diabetic retinopathy or maculopathy, we have a treatment. And this treatment, some of them, they are quite newish treatment. Now it's just, and the gold standards at the moment, we are in the UK, over the also Europe and the United States, is the injection. So if we have got involvement to the central vision, this is when the swelling, or what we call the edema. So let's make it a little bit simple for our audience. So the eye has got the sensitive part of the eye, which on the back of the eye we call the retina, and the central of the retina, this is the useful part when we see, which we see through, is the macula or the central vision. So if we have got involvement to the macula, this is when our vision starts to be blurry and starts to have problem seeing. And the treatment at the moment, the gold standards, is what we call it intravitreal anti-VEGF treatment. So this is actually when we inject this type of medication or drugs inside the eye, and this can last between 1 to 2 months, and it's dry this swelling, make it better. There are a lot of and numerous studies actually about this, including the RCR.net, Protocol I, Vivid and Vista. This is in the United States, Da Vinci, and they are all comparing the traditional way with the treatment, the old time with the laser, comparing to this injection inside the eye. Also, we have got the focal laser, which still like this place, micropulse laser, and also some steroid implant, we called it Ozurdex. And you can see here with the plan, we have got a little bit of swelling on the central vision, on the red, we can see it here. After the injection, it's all back green, there is no swelling. With proliferative diabetic retinopathy, this is the stage 3 or the advanced cases, where we have got these new vessels there, which this is the fluorescein angiogram, this is the dye test when we do it, so just to confirm it sometimes. The treatment is, at the moment, the gold standard is the laser treatment. You see this white spot around the retina, so this is the disc, the optic nerve, and this is the normal vessels. And the white patches, this is the laser marks when we do laser around the peripheral. This is the affected area. However, we have got new treatment, which again, the intravitreal injection, the anti-VEGF treatment, and they found actually this is the new studies, Protocol S and the Clarity studies in the UK. They found injection can help reduce the blood vessels growing and improve the vision, stop it from getting worse, comparing to the laser treatment. So this is also another option, which now in the state they are doing it as like most of the time as a first choice before the laser. But still, like laser is still like a good gold standards for us. In the very advanced cases when you have got tractional retinal detachment or a lot of bleeding inside the eye which not clearing, we do surgery, which we call the vitrectomy. I hope that was useful. I will just try to make it short. And thank you very much.